Welcome to SRC's Excellence in Action series, where we sit down with SRC accredited providers who are leading the way in patient care and safety within their healthcare specialties. I'm Dr. Neil Hutcher. I'm Chief Medical Officer for SRC. I'm a bariatric surgeon by profession and a former president of the American Society for Metabolic and Bariatric Surgery. SRC, which stands for Surgical Review Corporation, was founded in 2003 to address inconsistent results, serious complications, and patient fatalities associated with bariatric surgery. We set up standards and requirements to protect patients and sought accredited facilities and providers that met those high standards. What started as one accreditation offering has now grown into a global patient safety nonprofit offering more than 35 accreditation programs in more than 30 countries. You can learn more about our accreditations by visiting our website at surgicalreview.org. It is my privilege and pleasure today to speak with Dr. Arif Ahmad, an SRC Master Surgeon and Surgeon of Excellence with Mather Hospital Northwell Health in New York. Accredited in bariatric and robotic surgery, Mather Hospital was the first SRC accredited Center of Excellence for Robotic Surgery in New York. Dr. Ahmad is Mather Hospital's Physician Director of Bariatrics. He has helped transform the lives of more than 6,000 patients, improving their health and quality of life through his expertise and compassionate care. Welcome, Dr. Ahmad. And thank you for joining us today. We look forward to our dialogue and learning many things from your perspective. It is my understanding that your hospital recently achieved 10,000 bariatric surgical procedures. Traditionally, laparoscopic and open surgery has been utilized for these weight loss procedures. What led you to incorporate robot-assisted technology, and what benefits does it have for the patients and for the surgeons?
Yes, thank you, Dr. Hutcher, for the question, and thank you for having me at this presentation. It's indeed my privilege and my honor to be selected to be brought into the spotlight for our achievements at Mather Hospital Northwell Health. I founded this program in the year 2001, and I started doing bariatric surgery in 2001, and then we founded this program in 2004. And since then, we have achieved 10,000 bariatric cases and almost close to 10,000 robotic cases as well, if you look at robotic surgery in general at our center. I also founded the robotic surgery program at Mather in 2011. And then we got accredited in 2015, I believe, with the SRC as the first center of excellence in robotic surgery in New York State. So to answer your question, these procedures were generally done open. And then, in the beginning of my training, we were doing these procedures open. And I'm talking about 1995, which was my second part of my training. I initially trained in India and then in England, where I was both certified. I was a fellow of the Royal College of Surgeons of London and Edinburgh. And then I redid my training in the United States. And at that point, we were, I first joined Harvard, and we were doing, they were doing some procedures of these, these procedures were being done open. And then I did a residency in the University of Connecticut, where they were being done open as well. Then during my fellowship, we first started doing these in the University of Virginia in Charlottesville laparoscopically. So I've seen the whole gamut of open versus laparoscopic. And then in 2011, I started doing these procedures robotically. And in the beginning, there was a big question. Why do we do these robotic? Why don't we just do them laparoscopic? Or why don't we just do them open? And there was a lot of resistance in the bariatric community in terms of doing these procedures robotically. And this was a pet topic for me. I've been speaking around the world on the advantages of robotic assisted bariatric surgery. This year alone, I was invited in London by the British Society of Metabolic Surgery, the BOMS they call it, to do a keynote lecture on the advantages of robotic surgery in bariatrics. And then also presented in Vienna on a similar thing, at the IFSO in Vienna. And then the year before that, we presented in Istanbul and also in France at the IFSO. And almost every year we're presenting at IFSO or participating in some way on the advantages of robotic surgery in the field of bariatrics. So the first thing is that I think the advantages, to go into what the advantages are, unlike general surgery in slim patients, when we are doing a procedure laparoscopically in a slim patient, the abdominal wall is not as thick. Therefore, there's less fighting of the torque with the instruments that are coming in through those little ports. When the patient gets more and more obese, you're spending more energy fighting the torque rather than trying to get precision at the tip of your instrument. And this is something that we realized only after trying robotic surgery. Nobody really knew that this would be an advantage. So this is a huge advantage because now I can have a BMI 80, and really for me, that's the same as a BMI 40 or 30 because I'm using the same amount of force. All the fighting of the torque is happening with the robot. I don't have to do it. Also, when we do these procedures laparoscopically, the movement is happening on the whole instrument because it's a long instrument, so the whole instrument is moving. When I'm doing this robotically, just the tips are moving. So the torque is not involved at all. If you look at the way I'm moving my hands, just the tips are moving because we have wristed instruments. So that itself gives us a lot of advantage in precision and the ability to do things with greater precision and accuracy. Additionally, the robotic visualization is many, many times better. It's a 3D visualization with a magnified image, and it's unparalleled. Today, for example, I was doing a patient this morning that had a paraesophageal hiatal hernia fixed with a mesh before and a Nissen fundoplication. And since then, she became morbidly obese, and her hiatal hernia recurred, and the Nissen had slipped into the chest. And today I did for her a revision of her paraesophageal hiatal hernia with a mesh, and I did a bypass on her because of her weight. And of course, we took down the old fundoplication, created a Roux-en-Y gastric bypass, and the whole procedure took me about 2.5 hours. And this was with a lot of scar tissue, the kind of precision I could get with the tip of my instruments, with the enhanced visualization, with the advanced instrumentation. I couldn't achieve that laparoscopically. And I'm one of the pioneers of laparoscopic Roux-en-Y gastric bypass. I was one of the first people in Long Island to do it, one of the first 2 or 3 people that did it here in Long Island. So we're talking about, in spite of no matter what expertise you develop in laparoscopic surgery, see, there's one of my favorite statements is, the electric light did not come from continuous improvement of candles. You can get better and better. You can get better and better and better with laparoscopic surgery, but you can't. This is a paradigm shift. One of the things I say is that if open surgery is like the handwriting with your hand and a pen and paper, laparoscopic surgery was like the typewriter. But robotic surgery is like the word processor. You can do so many more things. You can share the file, you can add files, you can put things. And that's what we're finding. Today, for example, the other advantage is the advent of telesurgery and telepresence and live streaming. So today, for example, and I have a fellow in my program, and I told my fellow, you go to the office and we're going to see if we can talk, while I'm doing the procedure here, in the OR, you go to the office and we'll do a live telepresence from the office. And so she was watching from the office. We were interacting. We were talking about everything. She could see my picture. She could have a complete view of what I was doing. And my partner, who was in St. Charles, which is a hospital across the road, he could beam in from there to see what I was doing on this in between cases. And not just beam in, he could advise and talk, and whatever he had to say, we could talk about things. So it's a big paradigm shift. It's not just what you can achieve. The iPhone is not just another phone. You could say, what's the difference between a flip phone and an iPhone? The phone call is still the same. However, the iPhone does a lot of other things. It's a computer in your hand. The same way, when you do robotic surgery, at the tip of your instrument is a computer. This has never happened in the history of surgery. These leaps and bounds that we've taken haven't happened for hundreds and hundreds of years. That now we have got the same instruments, but we have a computer chip at the tip of the instrument, and that can achieve things that no mechanical instruments can achieve. So those are just some of the advantages. I can go on and on. This will take to really explain, but I think you get you get the gist of it.
Now, would you comment on the ergonomics and the decreased stress and tension on the surgeon's shoulders, arms, wrists, and all the other things that laparoscopic surgery affects?
Exactly. Very good question again. So when we started doing laparoscopic surgery, we had to really be like a contortionist. You had to move your hands and your fingers, and you had to do all kinds of movements, and my wrist would go all the way to the left and all kinds of, to the right in order to do things. And it was still very, very hard because you were working with a fixed fulcrum. Now with the robot, we don't have to do that. And then with the robot, the biggest advantage is you don't have to use any force to move your instruments, because all those force is taken by the robot. So ergonomically, it's made a huge difference. What it's done is it's extended the life of the surgeon. So I'm 65, but I feel like I'm 45. But in any event, I really don't feel tired. I do we got the days I'll do 6 bariatric cases. They give me 2-3 robot rooms, and I have a fellow and I have his PAs to assist me. But there'll be days I'll do 6-7 cases, and I'll go home and I'll feel like, I won't feel tired because I don't feel like I've exerted myself that much. That was unthinkable in the days of open surgery as well as laparoscopic surgery. So it has definitely improved the ergonomics for the surgeon, increased the working life for the surgeon if he wishes to work longer. And some people would say, why would you? But in any event, I think most surgeons enjoy that. And then the third thing, I think, which has made a big difference is that although we're doing this sitting down, one has to realize that as surgeons, my father was a surgeon too. So one of the first things he taught me, he said, you have to learn how to stand. Because if you don't know how to stand properly, you're going to ruin your back, you're going to ruin your neck, and you're going to be tired the whole day. So you have to learn how to stand erect. We did learn how to stand, but we didn't learn how to sit. So the robot is now, I tell my fellows, you have to learn how to sit. That's the first thing. So if you sit properly with your back erect, without your back slouching forward and your head pressing against the console, then I think that the ergonomics is much, much better. On the other hand, if one doesn't know how to sit, there's another famous saying, sitting is the new smoking. Sitting the whole day isn't so healthy for you.
Yeah.
So one of the suggestions I've made to the Intuitive company is you have those Varilux desks, where the office staff can move the desk up and then they can sit and then they can move it up. We were talking about doing that for the console. But these are all exciting and interesting things. But certainly the force that we use to do things is taken over by the robot. So it makes it a lot easier. I'm like playing a video game on the computer rather than fighting with my instruments.
With all the notoriety about artificial intelligence, robots, there are a lot of myths that have grown up around the word robot. How does that apply to robotic surgery?
Exactly. You're hitting all the important questions. Very good question again. And the answer to this question is, I think if you look at the reason why this myth has developed, is because the term robotic surgery is a misnomer. To the lay public, they would think that when you say you're doing robotic surgery, it's like the robot is doing the surgery, like your Roomba would clean your carpet, or they call it the different names of those carpet cleaning robots. But really, robotic surgery is not really robotic surgery. It's like the robot is a puppet It's like a puppet. When the puppet is moving, it's not moving on its own. Somebody's controlling the puppet. So exactly the same way, the surgeon controls the arms and the fingers of the robot, and he does the same procedure, on the computer using those controls that control those instruments. But really, the surgeon is doing the surgery, and the robot is really doing nothing. There's no artificial intelligence involved. There's no autonomy involved in today's robot. And it's just Dr. Kushieri, I don't know if you know him, he was one of the early ones who was delved into robotic surgery from Ninwell's Hospital in Dundee in the United Kingdom. And one of the early presentations that he did, they call it a slave-master relationship. In today's world, this isn't looked upon properly, but I guess it's really, so whatever the surgeon is doing, the robot is doing exactly that. Yeah. So it's a slave-master relationship between the two. There's no autonomy involved at all.
You had a rather mature, well-established bariatric program prior to your application for SRC accreditation. What were some of the driving factors that led you to seek accreditation?
So with reference to accreditation, I think the first thing that I'd like to say is that, the concept of having a center of excellence, which was initiated, as far as I know, by the SRC, really changed the playing field in bariatric surgery. Because, there were all these little programs without proper training, without proper setup. They were doing bariatric surgery, and they were giving bariatric surgery a bad name because of poor outcomes. And the SRC was the first to realize that the way to correct this problem is to have an accreditation body that would require stringent criteria to be fulfilled for patients to, have bariatric surgery at those centers. And then once Medicare said that they would only approve it at those centers, that was a major driving force for a lot of places. But for me personally, the driving force was, I think I wanted ourselves and the hospital to be held to certain standards, which would be to the benefit of both the patient and the surgeon and the whole program and the world at large, really. Because, if there's a requirement that you have to meet certain minimum standards before you can do it, then the hospitals would strive to meet those standards. And we were held accountable to meeting those standards. So we wanted to have the accreditation more than any other reason. In my first thought was, I would like us to meet certain standards, and I want the hospital to come to meet those. And I wanted to have a partnership. SRC started the concept of a partnership between a surgeon and his team, a seamless partnership between a surgical team and even if the team is in private practice like I am, and a hospital system. And we managed to get that collaboration going. And then the other driving force was the requirement from Medicare that they would only cover it at that point, in patients that were going to a center of excellence. So we wanted, and the third driving force, in my estimation, was we felt like we were doing a great job, but we wanted to be acknowledged. We wanted the world to know that we were doing a good job and we met those requirements of excellence.
Yeah. Well, we know that surgeons are the central part of a surgical center of excellence. We also know that surgeons can't work in a vacuum, and that you and your team have taken a multidisciplinary approach to the issue of obesity. How did your SRC accreditation impact your team?
Yes, so the SRC accreditation impacted our team in the forms that we had to meet certain minimum standards. We needed to do certain things, like maintain paperwork that showed that we did certain things that would meet those standards, such as regular meetings, educational sessions with the staff, educational sessions with the different, people in the multidisciplinary team, additional meetings in the multidisciplinary team, meeting certain minimum standards, making sure that we have the proper quality control that would meet up to the highest standards. And those things all helped us to have multidisciplinary participation in our care of the bariatric patient.
Well, one of the most important parts of our accreditation, and one that in the earliest days created a lot of confusion, was the concept of having pathways, clear education, ongoing patient support. How has this influenced your patient care practices and procedures?
Yes, and the concept of having pathways certainly, streamlined a lot of the processes and procedures that we do. And once we have pathways, it reduces the potential for error, because you can modify a pathway based on the patient's need, but certain factors have to either always be addressed. So I think that impacted on patient safety. The concept of pathways and the whole concept of education and support is a concept that we have then, since we first applied it in bariatric surgery, and since then we've been applying it to various other disciplines within surgery. So we're now using it for our general surgery patients. We have the same kind of pathways and educational sessions, etc. for the same thing. We're applying it in robotic surgery. We're applying it in general surgery as well. And I think this was first initiated, by our requirement to fulfill the criteria for the Center of Excellence as set up by the SRC. So these have impacts in patient safety.
With the advent of the internet and all of the things available for patients to become more sophisticated about their care, what are some of the things patients should consider when choosing a provider for their weight loss journey?
Yes, I think it's very important for patients to really do their homework and their due diligence when they embark on the journey of bariatric surgery, which is really just a tool. And so we want our patients to be able to get the tool safely, and then choose a program where they can get the tool safely, and then be given the resources from that program to use that tool in the most efficacious manner. So how can patients do that is the question. And I think the centerpiece in this is basically three things. Number one is the surgeon, because things that are done in the operating room, it's very hard to change those. Those are things that are very important, and they're kind of the beginning of this. And then the second part of it is, so they should research their surgeon. What are the qualifications of their surgeon? What are their experience? What kind of backup do they have? Do they have the backup of a more senior surgeon, with them to do these surgeries? Then the hospital that they're working in. Does the hospital have the facilities? Does it have a proven track record of success and safety? Does the surgeon have that too? And then what kind of team does he have? Does he have a team of nutritionists, a team of support staff, including, psychology and the multidisciplinary support team, the perioperative care, all those support systems, are they in place? And it's difficult for patients to get all these things addressed by themselves individually on the basis of, trying to do their own research. And I think having the stamp of a Center of Excellence from SRC does, I think, give patients some kind of a reassurance that the program has met a minimum standard. But I think beyond that, I think it's good for patients to do their own diligence. Because, now things have been muddied a little bit. I'm being very frank here. SRC required more stringent standards than the MSBQIP, in my opinion. And we were with the SRC since 2007 when we first got it. And many of the hospitals around us didn't meet those standards. They didn't meet the numbers, they didn't meet the standards, but they could all meet MSBQIP. Now everybody became an MSBQIP Center of Excellence. So the meaning of the word kind of became muddy, and because if everybody is excellent, then what distinguishes one from the other? So we decided to keep our SRC certification as an added certification, because we met that, there was a requirement of 125 cases per year at that time. And ours is, since then, there have been many years we've been in the 800 range, and our average now is around 500-600, between 500 and 600 these years. But what I'm saying is that, the hospitals with 75 around us and 50, and, I'm not just saying that numbers are all, but numbers do have an impact on this. And I think that we had watered down the criteria a lot. So it has become harder for patients to get the reassurance just based on whether somebody is an accredited center. And I think they'll have to do their own research more. And what I do is when I do my presentations, I tell them how many cases. I have a whole slide, a bunch of slides to say how many cases I've done, what kind of cases, how many were sleeves, how many were bypasses, how many patients had leaks, how many had, bleeding, how many were taken back for what reason. All that goes up there because it's already there. That data is already there with the SRC and MSPQIP. We are both. So then I put that data up because I like to share that with my patients.
Well, I'm very pleased that you brought that up because we're very proud of the term center of excellence. It's not center of good enough. It's not center of pretty good. Not everybody is excellent. So not everybody can be in the club. But having said that, you not only are distinguished as a surgeon of excellence, but you've gone the extra step to become a master surgeon as part of your accreditation. What does being an SRC accredited master surgeon mean to you?
Well, I think it's a recognition of my added experience and attention to detail and good outcomes. So I think that it's a recognition more than anything else. I think patients and other providers can see that stamp and get reassured that this surgeon has been vetted, in more ways than one.
What advice would you offer to other surgeons, other facilities regarding potential accreditation with SRC?
Yes, I would strongly encourage programs to get accreditation with SRC because it would require them to improve their processes and go above and beyond what they already have. It will be an impetus for them to move forward with going higher and better and performing better for themselves and their patients. Also, I believe that for people who understand the difference between the different accreditations, they'll appreciate that this program is more than just an accredited center. It's more than it really is, stands out from just mere accreditation to excellence, accreditation for excellence. So, many programs are accredited, but they don't get the same level of accreditation that I think that the SRC does. So I would certainly encourage surgeons to pursue this kind of accreditation because it will require them to improve their processes and improve their outcomes to achieve this milestone. And I think that in terms of advice for surgeons, I think that this is a field that we've taken a lot of trouble to make this an acceptable field of surgery where we've had good and acceptable results, starting from the days, of open surgery, where results were not so good necessarily, and now the multidisciplinary care, the better perioperative management of these patients, and the better training, and now with the advent of laparoscopic and then robotic, we've got better potential to treat these patients safely. I think that that it's also important to have that additional, surgeon who's starting out should seek out a more senior surgeon to be there by his side, when they're doing these kind of procedures. And then gradually, so I think it has to be, a combined approach. It's more like a transfer of knowledge and ability from a more senior surgeon to a more junior surgeon.
Yeah. Well, one of the leaders in the medical legal field, a lawyer, once had a statement that really stuck with me. And he said, you have to know what you don't know. Having gone through the process of collecting the documentation, the review of your pathways, your patient education, your informed consent, did that give you any insight and additional understanding of what you didn't know prior to your preparation?
Yes, I mean, in the beginning, when we first got SRC accreditation, you know, the all the aspects of the pathways that we built required us to look at different programs and understand how to build these pathways. What are the things that are important? And to do that, we had to do research and understand which aspect of a pathway is important. We, you know, at those days, we were not even sure about perioperative anticoagulation, its role, and there was debate whether we should do it or not, whether it would cause more bleeding or whether it would cause, you know, now it's kind of considered, for most people, it's considered standard of care. And then since then, we've advanced to extended DVT prophylaxis, where we do it even after they go home. So these kind of things, need for when do we start, what stage of diet, and all these different things. What's the importance of different perioperative management criteria. All those things have been, I've had to explore all those things in order to get, build those pathways. So it has certainly been very educative.
Well, Dr. Ahmad, I certainly appreciate your time, the expertise that you've developed over the years, your willingness to share it with us, and hopefully for the benefit of other younger surgeons. They might not be younger in spirit, but maybe younger in calendar days. I hope this will be helpful to others, and we look forward to continuing our relationship. And I can't wait to meet you in person and discuss other issues. So again, thank you so much for your time and what you've contributed for all of us in the field of bariatric surgery.